Today's topic for discussion is Bailey's palsy. Bailey's palsy, also called idiopathic facial paralysis, is defined as an acute onset, mainly within 48 hours, isolated, unilateral, lower motor neuron facial weakness. The annual incidence varies between 11 to 40 per 100,000 people. It is more common in people with diabetes. When we see the etiology of facial nerve palsy, the underlying pathophysiology of Bailey's palsy is vascular distension, inflammation, and edema with ischemia of the facial nerve. The etiology remains unclear, but various causes have been proposed, including viral, inflammatory, and autoimmune, and also vascular. Despite advances in neuroimaging, the diagnosis of Bell's palsy is mainly clinical. When we see the clinical features of Bell's palsy, signs and symptoms of Bell's palsy can vary from mild to severe. There are several conditions to consider in the differential diagnosis, including upper motor neuron lesion. In this case, based on innervation, absence of forehead wrinkling is a reliable way of differentiating Bell's palsy from upper motor neuron lesions such as stroke. Because the upper part of the forehead is innervated by both sides, so upper motor neuron lesion affects only the unilateral part of the brain most of the time. So in that case, absence of forehead wrinkling is a reliable way of differentiating Bell's palsy from an upper motor neuron lesion. In Bell's palsy, there is no forehead wrinkling. Herpes zoster oticus or Ramsay syndrome, this involves earache and air discharge in addition to the signs and symptoms of Bell's palsy. Rare causes include otitis media, HIV infection, sarcoidosis, and autoimmune disorders, and also sometimes tumors of parotid gland. Clinical features of Bell's palsy include weakness or paralysis of the upper and the lower facial muscles of the affected side, dropping of ipsilateral eyelids, inability to close the eyes completely, dry eye due to inability to close eyes, excessive tearing of the eye, dropping of the corner of the mouth, ipsilateral impaired or loss of taste of sensation, difficulty with eating due to ipsilateral muscle weakness causing food to be trapped on the affected side of the mouth, dribbling of saliva, altered sensation on the affected side of the face, and pain or mainly behind the ear, and also increased sensitivity to sound on affected side if stapes muscles are involved. In addition to ocular problems, complications of Bell's palsy include motor synkinesis. This is involuntary movement of muscle occurring at the same time as a deliberate movement. For example, involuntary mouth movement during voluntary eye closure. The other is crocodile tears. Tears when eating due to misdirection of regenerating gustatory fibers destined for the salivary glands, so that they become secretory fibers to the lacrimal gland and cause ipsilateral tearing while the patient is eating. Incomplete recovery, contracture of facial muscles, reduction or loss of taste sensation, and the problems with dysarthria due to facial muscle weakness can occur. When we see the prognosis, the severity of symptoms of Bell's palsy varies from mild weakness to severe paralysis, but the prognosis is generally good. One big study found that around 71% of patients recover normal function without treatment, and around 30% are left with slight weakness, and around 4% with severe weakness. When we came to management, the treatment of Bell's palsy aims to speed recovery and reduce long-term complications. Inability to close the eye on the affected side increases the risk of corneal complications. Eye protection is crucial, so an eye patch and the lubricants are used to prevent the drying of the cornea. Eye drops should be applied for lubrication during the day and the ointment at night. In severe cases, the eye might have to be tapped or partially sutured shut. When we came to the issue of drug therapy, the treatment considered for Bell's palsy include oral corticosteroids and antiviral drugs. Although the etiology of Bell's palsy is uncertain, it is known that inflammation and the edema of facial nerve are responsible for the symptoms. So, the maximum benefit of corticosteroids to reduce inflammation and edema is seen when steroids are commenced within 72 hours of onset of symptom. Prednisolone has to be used as a dose of 1 mg per kg per day up to a maximum of 80 mg daily for 10 days. The antiviral drugs used in trials were acyclovir and valcyclovir. Both are given for 5 days. Regarding combination therapy, a randomized controlled trial found that in 9 months of diagnosis, facial function had recovered in 94.4 patients who took prednisolone alone, 85.4% who took acyclovir alone, and 92.7% who took both. So corticosteroid alone is better than combination therapy in this case, in this study. Non-drug therapy include tailored fascial exercise, acupuncture to affected muscles, massage, and thermotherapy, and also electrical stimulation have been used to assist recovery. The palsy occurs in 7% of patients, with equal incidence of ipsilateral and contralateral recurrence. There are insufficient data on whether treatment affects the rate of recurrence or not. Thank you for watching.